So anyway, this presentation is about the health system and limited statehood. Although this term, limited statehood, is not used as that much in public health, in health domain, usually we use a different term, like the fragile. So I get it here to prove something different from the fragile state. So this is as a sort of introduction, maybe. So the whole issue is about the state. And I will argue here that state is not and should not be the only analytical tool to understand human activities, and specifically health, and more specifically health system and health governance. So, and that state is very new concept, few centuries, when Machiavelli mentioned in his book, The Prince, this word, lo Stato, mentioned about the centralized political authority. And a century after that, with this Treaty of Westphalia, they used the state, the sovereign state, as we use it now. So it's like just a few centuries when we start using the word state as a concept. With the state comes like another, terminology, like international borders or legitimate borders, and citizens, those who are inside these borders, and those who are enjoying national systems, different systems, including health system, that, conducted, run by, coordinated by a central government. I will come back to this one, this slide again later. So this could give some sort of numbers for those who like numbers. We're in this difficult world now. And then thank you, Bertie, for mentioning about Syria. As after 15 years, we're still with that struggle of basic issues, democracy, freedom, and all these issues. And not to forget, the whole Middle East and, other parts of Africa, Asia, and so on. So, these numbers, very recent numbers, so almost like 300 million people will require urgent humanitarian assistance. That's a huge number. 1.5 billion people live in a fragile state, as defined, by political science. So huge number. We're in a world with like 120 currently armed conflict, as defined by ICRC, whereas the other institute, the Uppsala conflict data program, mentioned to 59 armed conflict. The difference between these two is how to define armed conflict, but both actually are armed conflict. So it's about nuances in define. So the number of deaths here compared with the number of deaths there, the duration and all these issues. So, and because of all this instability, we're talking about now 122 million forcibly displaced, including 45 refugees just crossing the borders, and almost like 60, 70 IDPs who are inside, move inside the borders. What's new? Well, when I started working on refugees displacement more than a decade ago, the number in my first presentation, I put it here, was 40 million. So only in 12 years, the number now 3 times, triple, when I started, with all these efforts to talking about migration and displacement, and, and the number increasing. When you see the graphs, you see that, going up quickly. But we have something, new comparing with, decades ago. We start seeing that people move massively in a short time. Think about what happened in Gaza, just like last year. in Ukraine, in Syria. So massively, in millions, they move, in a very short time, a year or sometimes less in what happened in Gaza. And the average length, which is an important and sad, number of displacement, is 20 years. So you think that people move and almost never go back. And actually, I would argue that very, very little examples about return. So the whole issue of return could be a myth, unfortunately. Two-thirds of refugees are in a protracted situation. UNHCR defined protracted situation over 5 years. So any movement over 5 years is protracted. And now two-thirds of the refugees worldwide are in such a protracted. The more ignored and neglected group, the 70 million internally displaced, are also displaced in decades. And by the way, very little research on IDPs worldwide and also on health domain. The last, shocking number is that 3.3 billion person now are vulnerable or highly vulnerable to climate change. And some estimates saying that in the coming 2 decades or less, by 2050, the number of internally displaced because of climate change will be 250 million, mainly in Africa. So, and we know now from migration studies that when it starts as internally displaced, by time those will be displaced or externally displaced. But UNHCR still do not consider those who move because of climate change as refugees. So this is another issue to have a lecture on it later. So this is, what the political scientist Thomas Rice, tried to explain. Actually, the diagram I designed, I'm a failure, but I tried to show that, he defined 2 types of statehood: the completely failed state and the fully sovereign state. He said that examples from both extremes are very rare. We don't have good examples or many examples from fully sovereign states. The same with completely failed state. He defined, the fully sovereign as a complete control over territories, governance, decision making, and the most important, without external interference. So you can imagine that which state with this definition. On the other side, the failed state is a lack of any authority over territories and completely lost the monopoly of the means of violence. This is an important definition for the issue of the state. In between, we call them limited statehood. But limited statehood actually also with wide spectrum. We used to use the word fragile here. I will use here limited, and I will explain why. And this is the definition as per the political science, Rice, Drode, and others, about the limited statehood. These are parts of territories or policy areas in which central government lacks the capacity to implement decisions and or its monopoly over the means of violence is challenged. And please notice all these issues about the decision, controlling the means of violence, as the limited statehood. And I will show, a few issues here. One, it's not a binary concept. So, with like a very clear cut, it is limited or not. So there is a sort, as I said, a wide spectrum. Also, it's different from fragile and failed state. I will show that in the next slide. It could be, function equivalent to state authority, and also governance in these states relies on alternative modes, of governance, like partnership, participatory initiatives, rather than the traditional hierarchical one. So this is the definitions, of the three type of states: the failed, fragile, and limited statehood. I will just ignore this one, for time's sake. So, in a fragile state remains, intact, but struggle with the weak institution, corruption, ineffective governance across most of the territories. And we know that from, from our work. But what's different here, that in limited statehood, it lacks full control over parts of territory. As mentioned there, would sometimes maintain some governance function, from state or statehood. And to make it, more imaginable one, so think about Syria or Palestine, Gaza, or Myanmar. So I will jump. But before I will jump, I would like to read this quote from Rice. He said that limited statehood, doesn't mean that it's ungoverned. For the government, it's being governed is a function there. So it doesn't mean that it's ungoverned or ungovernable space. Actually, so governance can still take place through non-state actors or international organization and other mechanisms. Okay. So sorry. So again, this is the definition. I will jump because of time. Go to the three examples that I try to show it here in the presentation, and try to explain a few terms that I would like to argue about them, with you and with others. And this is Syria. To those who could have any idea about the maps, Syria. I mean, I don't have the map here. I should do it. Syria before 2011. It's something like this, but without colors, with one color, That's here. And then, we start seeing different powers, controlling different territories. And that change over time, and sometimes change massively, from this, to this, to this. This is just before the falling down of Assad regime that's in the late November 2024. You can see that several territories, this is the central government, the Assad regimes at time, the Kurdish side, the Turkish militia, groups that control these sides, the rebels or, some Islamist, groups here, and Israel control the Golan Heights, here, and then expanded to this area of what they call the buffer zone. So different powers, here, with, this is the term, this is the international border. And these borders, I call them power borders. And this is an important issue to think about, the difference between, having international borders and inside the power borders. You see that, after, the falling down, this green moved to be the entire Syria, almost. But, still we have the Kurdish area and the two Turkish-controlled militia something areas. But this, unfortunately, that was when I started preparing the presentation. That was in February, late February. Today we have, yesterday and the week before, we had also a different map. We have like a more, troubles here in this area and start seeing, and here, and with more also Israelis, moving up. So it's still the map changed by time, and this is an issue when thinking about systems, including health systems. Sorry, I'm speaking a lot political science, or but This is the reality when thinking about health. This is another example from Myanmar, but more complicated a bit, you can see. So, well, for what they call the junta or the central government are those in white. With some group here that with militia supported the junta. For the other color, starting from light blue to very dark on the borders, are different powers, different resistance forces, they call them. So it's a different forces that control different territories, many of them on the also border sides. And again, within 2 years, also the map changed. Well, that's the historical issue of Palestine, Gaza, and that's that after Oslo in 1993, there was a sort of agreement treaty, called Oslo Treaty, where the Israel gave the Palestinian authority, over two territories, the West Bank and Gaza. It's completely separate. There's no links between, the two territories. And even inside West Banks, you can see the complexity because the Palestinians are in that orange-like, settings, whether are light or dark. It depends on also they have what they call it Area A and Area B. More complicated about who's allowed to move and what documents they have. But also you can see many Israeli settlements inside that disconnect the continuity, in among the inside West Bank. And for Gaza, it was surrounded by what they called it no-go area. So all this line, it's a no-go area, except, three crossing, two controlled by Israel and one by Egypt. So you see, the concept of, in the three examples, the concept of statehood is a quite, how to say it, unclear, to say what is state in these cases. Again, one of the implications of that, as I said, the IDPs, and you see in the three cases, IDPs, disputed in different parts. And some parts are actually controlled by non-state actors, And what's the application for us, people working in migration, refugee studies, and so on? The main issue is about the definition. We use the term IDPs to define people who do not cross the border. If you do not cross the border, you're IDP. But if you cross the power border, what does it mean? There's no term, unfortunately, in political science, nor in health. And the implication of that, because if you don't cross the international border and you are IDP, the mandate, is for the central government. If you cross, the mandate is UNHCR. But if you're stuck in between, stuck here, or here. So this is the international border, and this is the power border. If you cross from here to here, or from here to here, so you cross the power border, but not the international. By UNHCR definition, you are IDP. By international law, by international, you are IDP. By reality, you are not. So that's a huge implication on health. So this is that people working in health system, know this definition about, health system governance. It's an, aggregation or, of principles, normative values like equity, accountability, within political system. So this is the issue. That's all the issue of governance defined within the political system. Whereas as we have seen, that, in the limited statehood, that definition of political system is different. Thanks to Ibrahim, my colleague and friend, who helped in doing like a quick review in health literature. We tried to find, linking limited statehood with health. Surprisingly, that Ibrahim found that the results for putting like limited statehood was like a 90 results. None has health as a primary focus. Zero article that clearly focus on health. And when he put like the two terms, limit statehood health. So in the title we have two results. I checked both. Actually, they didn't mention rightly to what we know about health, and that's the same in the abstract. Three results. So one about the church in the role of church in Philippines, about the sexual reproductive health. So, so the huge lack of interest, about health in limited statehood. I guess because we still define different statehood with the word that we use to define it in rebuild, as a sort of fragile state, without trying to explore these nuances between different definitions. And this is another exercise that we did, is to try to analyze the definitions of the famous definitions of governance, as done by different organizations, EU, World Bank, UNDP, USAID, and we found these are the definitions, the official formal definitions, and we found that there's a tendency to use the word government in all, five definitions. Some use the word country, and all of them use the word citizen in the definition or the discussion. For example, this is USAID, late USAID now. USAID, or they use the discuss the citizen participation. That they use it in the discussion. It wasn't the citizen. It's not in the definition, but in the discussion about the definition. And the same with WHO that may refer to citizens' rights. None of the five definitions use the word migration, refugees, internally displaced. None of the five. Although some mentioned about the some sort of term, but not in the core definition of the health governance. That talk about vulnerable population, and WHO and World Bank actually mentioned when discussing the health financing model. So Khalil et al. Did a sort of analysis of the 13 health governance framework. This is unpublished paper, so I get his permission, to get some sort of findings. He found that most frameworks that analyzed these frameworks, identified by Bion, in paper in 2016. So he found that most frameworks, this health governance framework, assume centralized or hierarchical structure. In a few framework, the legitimacy of the health system derives from the state structure. And legitimacy is another word that I will come back again because it's another issue. The power dynamic and distribution of power are between, in these frameworks, or some of these frameworks, between the government, intermediate institution, and providers. And then, most frameworks assign major role and responsibility. It's another criteria for health governance, assign it to the government, mainly Ministry of Health. So this is the challenges of measuring health governance and limited statehood. And these, the issue of validity, reliability, is an important issue when we don't have a good data sets on the governance and actors. So that's the same with talking about the contribution of non-state actors. Mainly, they are fragmented, and sometimes competing. The issue of security and security risk, that what happened again in our examples, Gaza, Myanmar, and Syria, when attacking health facilities, and health personnel, health workers in these areas of limited statehood areas. So that's bring another, difficulties in measuring health governance in these issues. And the final one is what's called now methodological nationalism, and this is defined in also political science as a concept in social sciences that refer to tendency to treat nation states as a primary and natural unit of analysis. And this is again that's the issue of all studies related to health governance. It assumes that national borders define the most relevant framework for understanding governance, society, and state functions. Very little or overlooking those who are non-state actors. This is the definition or the concept, sorry, of the methodological nationalism. Okay. These are some implications of the limited statehood for health governance. It's about the issue of the challenge in effectiveness and capacity. As I said, that the non-state actor may fail governance. Some part we know that there are governance, like what happened in, I don't know now, in Myanmar since decades. Some parts are with sort of governance. In northern Syria, in Kurdish area, it's also there's a clear de facto governance, but coordination is always difficult, between these two different actors. The issue of legitimacy is an important because legitimacy is what defines state. So state, as we know, as we have it, is legitimate by the international society. So without legitimacy, there's a problem here, in approaching that sort of concept and areas of understanding. And I will come back in discussing again the legitimacy. Also, there's, as I said, that fragmented governance in these different controlled area, mainly dependent on international aid and donors, and there's an issue of security. All these, put like a lot of implications on the statehood and health. So if we try to imagine what could improve that, so we think about a few determinants of having good health governance in limited statehood area, and one issue is the issue of legitimacy. And legitimacy could come from one of these three definitions or three sources. The input legitimacy, that local actors are involved in the decision makers. The issue of output legitimacy, where it's about the service providers, and the normative legitimacy, where we're talking about the external actor intervention. There's another determinant. It's about the task complexity, the institutional design, and I will try to explain all this theoretical issue in an example now about Syria. So in 2023, an earthquake hit northern Syria and southern Turkey. I will focus on the Syria part because this is for the sake of our presentation. So this is the area where the earthquake. Here, the earthquake hits three different areas. One is this area, that was controlled that time by the central government, and this area that was controlled by state actors, or what we called it now, limited statehood. And that area where Syrian refugees are there, it's a Turkish area here, but many Syrian refugees were in this area, southern Turkey. So what happened here, that in the first few days, the UN couldn't be able to send any humanitarian aid to this area, affected area. And if you remember, if anyone at that time read the news about the Martin Griffith that cried at that time because he had this negotiation with the central government for 6 days, then to be allowed to send some convoys inside to cross the border. At that time, the main argument is about the legitimacy. So, if you want, the central government said, if you want to go through, we are the legitimate government to go to deal with and to send the aid at that time. So that's delayed. Actually, you can imagine that 6 days after earthquake, how many people died, after that. So that's the issue, when talking about the legitimacy and the importance, understanding that and improving that when talking about limited statehood. The issue of task complexity. Some tasks were quite like a simple task, like providing, food aid or that came from Turkey, that side. But some complexity, what they called it, complex, task, including the infrastructure, removing, the remnant, the rescuing people. So this complexity affected strongly by that definitions or that, a sort of misdefinition about the powers in the region. The last issue is about the institutional design with like a UN and WHO similar, with like facing a lot of bureaucracy that time, to send aid. This is also in Myanmar. So the junta or military junta doesn't control enough of the territory to uphold the core duties of the state, and this is another issue because that sort of limited control affected strongly their duty in terms of health system and health governance. I would suggest here, in the in the rest of 4 or 5 minutes, a new mode of health governance that could address this new concept of limited statehood and improve the governance. One, there should be sort of non-hierarchical coordination. That's important because the model that we know in health governance is very hierarchical. There's center and there's sort of district or remote areas. And the other issue is about having more participatory and multi actor involvement in rebuild. We use that sort of although it's in a limited area in Lebanon, but we use that strongly about the issue of participatory approach and engaging multi-actors in that. Context specific is highly important. Even in one country like Myanmar or northern Syria. So these different territories have like a different specific context. Kurdish area, because of cultural issue, are different from northeast side, because northwest side because of that's mainly Arabs and Sunnis and so on. So this is an important to think about when developing that model about the context. So it's important to have a flexible regulation and soft law and the issue of transnational or and multi-level governance, as defined by Abimbola. He suggested the three different type of multi-level governance: the operational level, the collective level, operational level on the level of individuals and providers, the collective levels on the issue of community, and constitutional level is the government if needed. And this is the what called it the people-centered approach, where we have, that's the operational one. We have like a context of the geography where we do that model, the socio-economic context, and the institutional one from supplies and demand side. Usually, the health governance system that we use, the model is mainly about the supply side more than the demand side. And also, this is a suggestion, about the issue of where the focus will be. I choose only 3 out of 5 of the definitions of of governance by WHO, EU, and World Bank here, and put one that I adopted from Scheiter, about the limited statehood. So the focus here is policy, equity, and universal health coverage. That's WHO focus mainly on. And EU about the policy coordination. World Bank about efficiency, financing, institutional role. And here, the focus should be more on the social coordination beyond government. The actors mainly are government-led in the WHO model, or private public. Here in the World Bank, government that market. In that suggestion for definition for the limited statehood, it should be also public-private and NGOs a donor. But the main also argument here is what is public in such a sort of limited statehood. If we don't have government, then what is public? Is it that facilities run by NGOs, international organization, is about because it's free of charge? So there's a need to discuss more about, again, the terminology. Well, I have 5 minutes. Thank you. So I would recommend few issues. Although I hate the word recommendation, to be honest. I mean, just want to recommend whom. So I'm just trying to say what should we do? Next step, say. Next step. Okay, better than recommend. So first, here where we focus mainly, in our work in health system and health governance in a specific. We focus on the national, the state, as I mentioned. But we know that we have some research on the subnational, district, or sometimes local, like again what we do in Rebuild. We know now there's a lot of work on the global level. So this global system, and we have global health and the global system, and all these issues. But we know now there's very little work on these areas, like a cross-border. What's in between this border? How to? Okay. So, well, this is Lebanon. This is Syria, of course. So, and people move. Many refugees move here or here. So what about, that sort of exchange across the border? What sort of system, given that, for example, in northern Syria, if needed sort of high-tech medication or surgery, they smuggled people to the cross-border to Turkish side, to do that. And sometimes actually with the help of international organizations. So there is a sort of what Omar Diwaji once, name it as therapeutic geography. So sort of exchanging cross-border. Very little, if any, research on that cross-border structure of health system. So again, that's with the same as I said, with regional also, system. We have national system, but we don't have regional system. We don't have Middle East, health system, or East Mediterranean, health system when talking about, even one population. For example, Syrian refugees, now live in, three neighboring countries: Jordan, Lebanon, and Turkey. But each of these countries, has their, own system. But the population, the target population are the same. And I have a story about that, but maybe in the questions, So, and again, as I argued here, in all these presentations, there's nothing here. So that's my first way to go. Second is we need to improve the measurement of governance and limited statehood. We know that, as I mentioned, there's a lot of uncertainty about the measurement because there's a less empirical work on that. So it's important to work on subnational, data, generating subnational data, and cross-border data, this is what I would suggest to add it. We have some work on subnational, but we don't have data on cross-border, and to have create, I don't know if create is the right word, some sort of new indicators to consider this complexity of governance, including the various actors and the difference between central state and non-state. The last issue is, well, it's time now to include other disciplines. I know, I start my life career as a surgeon. Then I moved to public health. Then I moved to global health. Then to refugees. During this journey, I saw more and more that other domains are really important. To put this presentation, I found myself reading a lot about political science. Thank you, Ian. So there's a lot of issues to do with that. And then, of course, we know this, political economy component of health, like the social determinants of health. But also I would encourage including history as an historical event. We know after the COVID now, that's, COVID pandemic, that history also is a very important determinant to include when talking about global health and health system in a new context like non-state. And what else? So, yeah, I don't think there's anything else. Well, that's the last one. That was the first presentation, first slide. I mentioned state. But again, we should go with nuances about fragile state, areas of limited statehood. We have this, focus on international borders. But what about the power borders, And what about the cross borders, that have different definitions on that. Citizens, are the main target population in the health system. Then the residents, migrants, refugees, IDPs, stateless, all actually have a secondary and sometimes, less, interest about it. Again, moving from national, system to subnational, system or supranational system, whether it's a cross-border or regional or international, and from centralization by fiat into decentralization by default. Thank you.